Sepsis in pregnancy. Okay, I think previous speaker Dr. Baba already explained why mothers die. I just re-emphasize about it. Okay, so this is taken by the WHO, World Health Organization. Okay, this is a systemic analysis why mothers die worldwide. Alright, and my topic is sepsis, so we just go through sepsis. So worldwide, the incidence of sepsis is about 10.7% or about 11%, and it's most in the Southern Asia, which the Southern Asia about 30.7%, right? So how about in America? So in America, their incidence, why mothers die in America, sepsis actually play a big role, about 11.1%. It's as the same as hypertensive disorders of pregnancy. Okay, how about our country, Malaysia? I'm sorry, my data is 1 year outdated compared to Dr. Baba just now. So from 2015 confidential inquiry of maternal death, it's stated here the word sepsis, I only can found here, puerperal sepsis, which is 0%. So I'm not sure whether this is because, but after during the 2016, the data shows that the cause of death, puerperal sepsis, was 7 from our previous speaker. Right. So why is sepsis is not really reported in our confidential inquiry of maternal death? Is it because it's very difficult to define sepsis? Is it because we don't know what is sepsis, what is severe sepsis, as it keeps changing over the years? And some data actually mention about pregnancy-associated severe sepsis, which is fast, or maybe puerperal sepsis is just a subset of sepsis. It's just infection of the genitourinary tract. But sepsis itself is a very big topic, and half an hour is not enough for me to explain about it. Alright? So we are talking about maternal mortality. We know we have been doing very great about maternal mortality. We reduce our mortality rate. By now, WHO already mentioned about we have to look at morbidity. What causes maternal morbidity? That's when after pregnancy, they don't go back to their quality of life just like before pregnancy. Right? This is true because for this year, most of my ICU admissions was sepsis in pregnancy. All my maternal cases mostly come because of sepsis, and the latest patient was melioidosis in pregnancy. So it caused morbidity for this patient. She had been admitted at least 2 weeks in ICU, get a drain for the liver abscess, for the spleen abscess, the acute kidney injury. So it's actually also, we can call it sepsis in pregnancy. So and it contributes significant morbidity for pregnant lady. Okay, this is a UK study from 2011-2012 where they do a national case control study. From this study, it shows that for each maternal sepsis death, approximately 50 women have life-threatening morbidity from sepsis. So even though there's a 1 patient who died, back then is a 50 patients who have sepsis actually had impact in their life because of sepsis. Okay, so what is sepsis? Sorry. Saya kena buka semua. Okay, sorry. So what is sepsis? Actually, the sepsis is a disease, even though it's from the Hippocrates area, we still don't know, we're still learning about sepsis. So sepsis definition had been changes from 1991 to 2016 about 3 times. So in 1991, they mentioned about SIRS criteria, and then in the 3rd international consensus definition for sepsis, published in JAMA 2016, sepsis was defined as a life-threatening organ dysfunction as a result of a dysregulated host response due to known or suspected infection. So this is the latest definition of sepsis. From this guideline, they already take out the definition for severe sepsis. So there's no more severe sepsis. You only have infection, sepsis and septic shock. So the definition of organ dysfunction was defined when there's a SOFA score more than 2. SOFA score is actually a sequential organ failure assessment score, which is more than 2. So any patient who has infection and the SOFA score is more than 2, we define them as sepsis. So the SOFA score is actually the routine score that we use in our ICU. So it defines, it's called 0, 1, 2, 3, 4, and it consists of most of the systems in our body. So we have respiration, we're using a PF ratio, coagulation, we're using platelets, and bilirubin for GI tract. Cardiovascular, we use the mean arterial pressure and also the requirement for vasopressors or inotropes. GCS score for CNS, and for renal, we use the creatinine and urine output. So if there's a more than 2 score from the SOFA score plus infection, we define it as sepsis. Right. So what is maternal sepsis? That one is the general definition for sepsis. So after the 2016 definition came out, this group of experts sit down and decide what is the definition of maternal sepsis. It's still not validated. They are still waiting for a global study to validate this definition. But as for now, maternal sepsis is a life-threatening condition defined as organ dysfunction resulting from infection, whether it's during pregnancy, childbirth, post-abortion or postpartum period. So usually response to infection will be a normal health response. You have fever, you feel unwell, lethargic, and then you give antibiotic, they recover well. But what happened in sepsis was there's an infection, there's a dysregulated host response, whether they become hypo-responsive or they become hyper-responsive, and they develop organ dysfunction and develop septic shock if it's not controlled or treated, and later death. Right? So what is septic shock? Septic shock is actually when there's a circulatory and cellular metabolic abnormalities which was profound enough to substantially increase in mortality. I think they don't run the red color. Right. So the circulatory abnormalities were defined as persistent hypotension that requiring vasopressors to maintain AVP more than 65 mmHg. And the word is N. It must be together with metabolic abnormalities, which is serum lactate more than 2 millimole per liter. Okay, why is it very important? This is the general population, a non-pregnant lady. They found out that once we diagnose a sepsis, that means they are SOFA score more than 2, or there is there's organ dysfunction, the mortality can go up more than 10%. But once patient has septic shock, that means there is a requirement for vasopressors to maintain their AVP 65 mmHg, and when the lactate is more than 2, the mortality can go as high as more than 40%. But we see lower mortality in our obstetric patient because this study published in 2008 shows that in general population, mortality due to sepsis or septic shock can go up to 80%, but for pregnant population, it's as low as 30%. So they mentioned here is factors associated with the decreased mortality was because of all the pregnant lady was in the younger age group. The type of organism usually less virulent compared to general population, and overall they are from a healthy population. And usually if there's a needed for source control, pelvis are amenable to surgical and medical intervention, and usually diabectemia is just a transient. Right. So this is the article from Beverly Lawton, Preventability of Severe Acute Maternal Morbidity. The final here is the most common causes of preventable severe morbidity were blood loss and septicemia. I think we are doing very good with our hemorrhage, postpartum hemorrhage and all that. We have spent a lot of money and resources to prevent maternal death due to hemorrhage. But I think for sepsis, not only in maternal group, for general population, even in adult population, this has been lacking in concentrating how to prevent patient die because of sepsis. Okay. So from juga ada yang betul. It's okay. Okay, for this year report of confidential inquiries into maternal deaths in the United Kingdom, they say that maternal deaths relating to sepsis are often associated with failure to recognize the severity of illness. So it's the failure to recognize the severity of illness that cause patient to die. So it's preventable. Why is it happen? Because in obstetric patient per se, there's an overlap between physiological changes in vital signs and inflammatory response. We know that in pregnancy, they have physiological changes. Example like in cardiovascular system, there's a increase in heart rate compared to the non-pregnant lady. The systemic vascular resistance also reduced, So sometimes we relate to diagnosing patient with infection or sepsis because of their physiological changes during pregnancy. So we assume that the physiological changes is because of pregnancy rather than the first or early signs of sepsis. Secondly is immune modulation during pregnancy leading to differential response to infection. Last time we said that pregnancy is an immune suppression, but this was no more. So the term was immune modulation. So patients who are pregnant, they respond differently to infection. Some they respond like less severe compared to non-pregnant lady, but some respond severe or more severe illness when they get it during pregnancy. Example, if they have malaria in the early pregnancy, they usually turns more severe. And if they develop respiratory infection like H1N1 or viral infection, they tend to do worse compared to the non-pregnant lady. So that's due to immune modulation during pregnancy. So how their response to infection is different compared to non-pregnant lady. So other problem was source of infection was not apparent. Okay, from this maybe WC Barton, it mentioned that source of infection was not apparent in 44% of their patients with septic shock. So usually they come with the clinical signs of infection, but the source of infection is not apparent. So that's why we diagnose them as sepsis late. And usually they deteriorate very fast. From these studies, they said that time from the first symptom of infection to full-blown sepsis was less than 24 hours in 39% of patients. And half of the patients who died, the onset of infection to death is very fast, which was less than 24 hours. So let's go through, this is quite latest study, 2016, open maternal mobility and mortality from severe sepsis, also a UK study. It shows here that those who, this is the characteristic and relative risk of severe sepsis among pregnant and recently pregnant women. It shows that those with a younger age has a higher risk to develop sepsis, and also those who are in the higher age group, more than 40. Maybe because more than 40 is their comorbidities, diabetic, hypertension and all that, and the younger age group usually they are from a low socioeconomic status family. And here is, it shows that the lower the socioeconomic status of the patients is, the higher the tendency to develop a severe sepsis. And the mode of delivery, okay, the mode of delivery, cesarean section is known to be an independent risk factor to develop a severe sepsis, just like multiple birth and stillbirth. From the same study, it shows here that previous years, the commonest cause of sepsis is genitourinary tract, But from in 2010, the source of infection is mostly from the chest infection. And the number of organ system dysfunction when they come to ICU at least more than 2. And the commonest organ system dysfunction involved was cardiovascular and respiratory. And this is the numbers of patients who survive from sepsis, and this is the numbers of patients who then become of sepsis. We can see even though the numbers of patients who less than 35 is a lot, but they do better compared to the older age group because of they have a better response to treatment. And we can see that most of patients who die quite have a high BMI. So obesity also seems to have a poor prognostic patterns in sepsis. And the other one is when they have a chest infection, they are more difficult to treat, and the numbers of patients who die because of sepsis is higher in this chest infection group. And once they involve respiratory and hematological system, the increase in the number of deaths from this group. Alright? So how about screening? Okay, this is supposed to be screening. Alright? So as the cause of death in sepsis is failure to recognize sepsis or septic shock. So this is for adult population by Dallinger, the feature of sepsis performance improvement. It says that screening for sepsis are associated with improved patient outcomes. Right. So from the third international consensus of definition of sepsis, when they publish the definition, they suggest that all patients with suspected infection, when they come to ED in the ward or any other except in ICU, they suggest to do a Q-SOFA. Q-SOFA is a quick assessment of the SOFA score. Just now what I told you is the full SOFA scoring system. These are quick SOFA variables, consist of respiratory rate, mental status and systolic blood pressure. So each of these score about 1. So if respiratory rate more than 22, you score it 1. If the mental status GCS less than 15, 14 and below, you score it 1. And the systolic blood pressure less than 100, you score it 1. So if the Q-SOFA is more than 2, and there's evidence of infection, we have to go and send all the lab investigations and calculate the SOFA score. So if the SOFA score is more than 2, yes, it is sepsis. But if less than 2, if you still suspected sepsis, you just have to monitor and recount the Q-SOFA, right? But they introduced this Q-SOFA because they found out if the Q-SOFA was 0, the mortality was less than 1%. But when the Q-SOFA more than 2, mortality was more than 10%. So it's actually screening for outcome rather than diagnosis. And we know that obstetric patients have a different outcome compared to general population of sepsis. So it's just a scoring for outcome rather than diagnosis. So they introduced a early warning score. So you can see it's early warning score. So they modify it to obstetric population. And the purpose is to early recognize sepsis and respond to patient deterioration. It's not validated though for use in obstetric patient. So this paper, this new modified early warning signs, score the patient 0 to 3 in the extreme physiological parameters for systolic blood pressure, heart rate and respiratory rate, temperature and mental status. So it has been used for quite some time in UK, but after this paper published, okay, they find out that whatever you use scoring system, SIRS, News, or now the latest one, the obstetric score, it does not identify accurately patients who are at risk for developing a severe sepsis, admitted to ICU and all that. So they suggest it should not be used in the obstetric setting. So usually what I will do and I suggest you do, there are 2 ways for us to screen a patient with sepsis. The first is any patient with infection, right? You can see there's evidence of chorioamnitis, you can see there's evidence of maybe a seizure wound infected, or maybe a cough or SOB because of pneumonia. So first is infection evidence by signs of symptoms. That means there's a fever, tachycardia, one peripheris, bounding pulse, and then you send your laboratory test. There's an increase in the total white count. You send the CRP is high. If you have procalcitonin is high, and then you can see there's a possible source of lung infection, such as you can see the chest X-ray. There's a causal relation. You auscultate the lung. There's a crepitation. There's a bronchial breath sounds. You can see there's a cloudy urine, or patient complaint of loin pain, right? And when you send all the microbiology, it comes back as a positive culture. So there's evidence of infection. You have to find very hard whether there's evidence of organ dysfunction. Just like whether it's a QSOFA or SOFA score. So try very hard to find evidence of organ dysfunction, and then you can say that the patient has sepsis, so that all the sepsis treatment can be done as soon as possible. There's another scenario where you can see there's no obvious source of infection, but you can't explain why patient have organ dysfunction. Example, the patient increases in the FiO2 requirement. From nasal prongs, you go up to ventral mass and then high flow mass, or your urine output coming down, or the creatinine or renal profile worsening. There's an unexplained organ dysfunction. So we have to try very hard to look every possible cause of source of infection, whether by clinical examination, laboratory, microbiology, and etc. And if there is evidence of organ dysfunction and infection, we define it as sepsis. Alright, so these are the possible causes of sepsis. It can be defined as an obstetric cause or non-obstetric causes. The obstetric causes including the genital tract causes like choroamnionitis, endomyocarditis, septic abortion, wound infection, and non-genital tract causes like pyelonephritis, lower UTI, and non-obstetric causes like HIV patient, pneumonia, TB, and malaria. So, as I said before, it's very difficult to develop a screening tool for sepsis. So what we have is our guess-stop. We can't guess if patient has sepsis or not sepsis. It's not right to do it. And we are not a genius to say that once you diagnose sepsis, it's 100% true. So what we have is our guess-stop. So at the moment the patient comes to you, whether there's evidence of infection, whether there's evidence of organ dysfunction, we have to find there's a two of things present, infection and organ dysfunction, by means of all the clinical data that we have from our clinical examination, from our laboratory finding or microbiologists, as soon as possible, using our guess-stop. That means our clinical judgment, our experience, whatever that we have to diagnose sepsis. Alright? So because once we diagnose sepsis, we have to start the treatment or resuscitation as soon as possible. So this is a published in Critical Care Medicine in 2016. Surviving Sepsis Campaign, International Guidelines for Management of Sepsis and Septic Shock. This is for adult sepsis patient. They don't have study for maternal patient, so we can use it as a guideline also for maternal patient. So this guidelines is actually the initiative of the Society of Critical Care Medicine and also European Society of Intensive Care Medicine to use the latest evidence base to reduce the mortality due to sepsis. So these guidelines will be revised every 4 years according to evidence-based medicine, and the latest guideline was published in 2016 and was revised in 2018. Right. So from this guideline, it mentioned that sepsis and septic shock are medical emergencies. It's a medical emergencies, and we recommend that treatment and resuscitation begin immediately. So that's why we have to diagnose sepsis early, because it's a medical emergencies and the treatment and resuscitation must be begin immediately. So in 2000, when it was introduced in 2004, they advised by the 6 hours the resuscitation must be done, and then it became lesser to 3 hours. And now 2018, they said all these things must be done in 1 hour after diagnosing a sepsis. So time zero or time presentation is actually the time patient presented to ED. Even though the diagnosis of infection is not done or sepsis is not done yet, it's already a time zero. So if you are in labor room, in the ward, in the KK, once patient has show signs of infection, it's already a time zero. So within 1 hour, you have to measure the lactate. Alright? And if lactate is more than 2, you have to re-measure again the lactate within 1 hour. And then we have to obtain blood culture before antibiotics, and we have to give a broad spectrum antibiotics. And if the patient is hypotension or lactate more than 4, we have to begin rapid fluid resuscitation, 30 ml per kg crystalloid. What we have is normal saline usually. Alright? And if still during the fluid resuscitation, the mean arterial pressure still can't get more than 65 mm/Hg, they advise to start the vasopressor, no adrenaline during the fluid resuscitation. Alright? Okay. So the second one is the source control. I just want to mention this about source control. So from this article, it says that infectious foci suspected to cause septic shock should be controlled as soon as possible following successful initial resuscitation. So after the resuscitation, we have to find the source, and if it's can be controlled, whether it's percutaneous drainage, whether it's open surgery, it needs to be done as soon as patient was optimized. Not normalized, but optimized, right? A target of no more than 6 to 12 hours after diagnosis appears to be sufficient for most cases. Right, about antimicrobial therapy. So they suggest, the Surviving Sepsis Campaign 2016 suggests to commence antimicrobial as soon as possible and within 1 hour following regulation of sepsis and septic shock. And any delay, every hour delay will increase mortality of patient with sepsis and septic shock. And we have to give a very broad spectrum therapy with the suspected infection. If pneumonia, it must cover atypical. If UTI, it must cover the commonest organism. If GI tract, it must cover Alor. So it must be a broad spectrum antibiotic. And the dosing must be according to the patient pharmacokinetic and pharmacodynamics. Patient with end-stage renal failure will be different. Patient with heart disease will be different, right? And we must remember to de-escalate. So yes, we have to start broad spectrum antibiotic, but they also suggest we have to de-escalate once we identify the pathogen and we establish the sensitivity and the patient shows clinical improvement. So this is my last slide. Okay, I just want to introduce, currently there's an ongoing studies by WHO, maternal sepsis incidence, etiology and outcome for mother and fetus, a prospective studies. Is determine the incidence of maternal bacteremia during pregnancy, and this is not this is just this is not an ongoing study. This is a study that show that the commonest organism they found is E. coli and group B streptococcus, and the causes are genital tract in 61% of patients from this study, and urinary tract was 25% from this study. And sepsis actually associated with high preterm delivery and high perinatal mortality rate. Right? And this is my slide, okay? This is a global study, a global maternal sepsis study. So this study is part of the WHO initiative for global and maternal and neonatal sepsis initiative. They try to find out what is the best screening method to one is to develop and validate a set of criteria for identification of possible severe maternal infection. Second, to assess the frequency and the outcomes of maternal sepsis in developing and developed countries. And third is to assess the frequency of use of a core set of practice recommended for prevention, early identification and management of maternal sepsis. So this is ongoing studies. I hope to see the results soon. And for us, we have to know that sepsis is preventable, and most of patients die because we fail to recognize sepsis. So it's our job to recognize sepsis as soon as possible, because any delay in treatment of sepsis, the cause is the patient's life. So as a summary, sepsis is potentially deadly. Morbidity and mortality from sepsis can be preventable if we diagnose early and start treatment early. Sepsis is easily missed, especially in pregnant lady, because of the physiological changes and immune modulation. And suspect sepsis in every patient with infection. Use your guess talk, alright? Don't depend on the numbers. And aggressive approach, 1 hour bundle, and soft control as soon as possible. And more study needed because sepsis is something that's still lacking in understanding. Right? With that, for us in our hospital level and our department, I just want to announce that 13 September every year is World Sepsis Day, including maternal and fetal sepsis. Is our we first celebrate our Sepsis Day last month in this auditorium. Alright, with that I thank you.